Neurology Quiz number 77. Describe the genetics, pathology, and clinical features of the core myopathies. The core myopathies are the commonest type of congenital myopathy. Congenital myopathies are a group of genetically and clinically heterogeneous group of muscle diseases which are usually present at birth, are associated with early infantile or childhood onset of hypotonia, cause motor weakness and developmental delay, generally have a static or slowly progressive course. Congenital myopathies are rare disorders and the overall prevalence is 1 in 25,000 individuals. Core myopathies are further subdivided into central core and multi-minicore myopathies. Pathologically, central cores are longitudinally extensive areas within the center of the muscle fiber, devoid of mitochondrial enzyme activity. Multiple smaller areas of reduced activity affecting shorter segments of the muscle fiber are seen in multi-minicore myopathy. Genetics. Central core myopathy is most often caused by autosomal dominant mutations in the skeletal muscle ryanodine receptor or RY-R1 gene on chromosome 19. Autosomal recessive mutations are less common and are associated with a more severe phenotype. Minicore myopathy is most commonly caused by autosomal recessive mutations in the selenoprotein N1 or SCPN1 or selenon gene on chromosome 1, but can also be due to autosomal recessive RY-R1 mutations. This figure in the top panel on the left shows an NADH stain which is showing cores centrally in almost all the fibers. On the right, ATP 4.2 staining showed that almost all the fibers were type 1, and in the bottom panel is a magnified view of the central cores. In this figure, the top panel shows an NADH stain on the left, which demonstrates multi-mini cores. On the right, ATP 10.6 staining showed that the fibers with cores are type 1. In the bottom panel, multiple multi-cores are demonstrated in the form of multiple internal clear zones in muscle fibers with an NADH stain. Clinical features. Autosomal dominant central core myopathy patients present with hypotonia, mild and symmetric axial and proximal muscle weakness with delayed motor milestones. Patients achieve independent ambulation, though this is usually late. The course is most often slowly progressive or non-progressive. Extraocular and bulbar muscles are spared in the dominant type. Cardiac involvement does not occur. Musculoskeletal abnormalities include joint laxity, congenital hip dislocation, kyphoscoliosis, as well as pes cavus and pes planus. There can be variability within the same family, with some individuals being asymptomatic and others presenting with hypercikemia, exertional myalgia, and rhabdomyolysis. Autosomal recessive central core myopathy can manifest as severe neonatal weakness and respiratory failure. Involvement of extraocular and bulbar muscles is also seen. Such patients often require early respiratory support. The most severe forms present with arthrogryposis. This figure shows features that can be common to congenital myopathies: a myopathic open mouth posture, a long face, and mild ptosis, as well as a Gowers sign on the right. Multi-minicore myopathy can present during infancy with feeding difficulty, axial hypotonia, progressive scoliosis with or without spinal rigidity, as well as early respiratory impairment out of proportion to the degree of skeletal muscle weakness. Involvement of extraocular muscles is seen in cases related to autosomal recessive RY-R1 mutations. Muscle ultrasound/MRI shows a distinctive pattern of involvement in RY-R1 core myopathies. There is selective involvement of the anterior and medial compartments of the thighs. This is unlike other congenital myopathies that predominantly affect the posterior thigh muscles. Patients with central core myopathy and RY-R1 mutations are at risk for developing malignant hyperthermia. These conditions are allelic disorders related to RY-R1 mutations that lead to impaired excitation-contraction coupling and abnormal calcium homeostasis. There have been no reported cases of malignant hyperthermia related to SCPN1 mutations. Malignant hyperthermia is a hypermetabolic response to inhalation of anesthetics such as halothane, desflurane, and sevoflurane, as well as the depolarizing muscle relaxant succinylcholine, and rarely can be provoked by vigorous exercise and heat. This figure shows some of the clinical features of multi-minicore disease. These include wasting of the shoulder girdle muscles in A, scapular winking and exaggerated lumbar lordosis in B, and characteristic stance with flat feet and genu valgus deformity in C. External ophthalmoplegia is seen on upward and lateral gaze in D and E. This figure demonstrates selective involvement of muscles in RY/R1 related central core disease. This is a muscle MRI of the thigh, T1 weighted image. There is a distinct pattern of selective involvement characterized by marked increase in signal within the vasti, sartorius, and adductor magnus, and relative sparing of the rectus femoris, adductor longus, gracilis, and the hamstring muscles. Treatment of core myopathies is primarily symptomatic. Orthopedic complications such as kyphoscoliosis or congenital hip dislocation require multidisciplinary support from orthopedics and physical medicine. Respiratory involvement is common in the severe types, and patients need regular pulmonary function testing to determine requirement for non-invasive or invasive ventilation. Aerobic exercise such as cycling or swimming can help promote aerobic fitness. Patients with RY/R1 mutations susceptible to malignant hyperthermia should wear a medical alert bracelet.